Hello everyone, and thank you for the invitation to speak at this Liverpool Research Society conference, focused on the theme of healthcare for the 21st century and beyond. I am currently the Royal College of Emergency Medicine Professor, a consultant in emergency medicine at the Royal Infirmary of Edinburgh, and I'm the Research Director for eMERGE, which is our emergency medicine research group. My research interests lie in challenging areas of acute care and the innovative use of novel technology to improve healthcare in this difficult setting. And today I'm going to talk to you about how novel ambulatory monitoring technology can improve care in cardiovascular conditions such as syncope and palpitations. So on the left is where I work, and on the right is my team. As you can see, emergency medicine research is satisfying, fun, very much a team sport, sustainable and extremely varied. No 2 days are the same in emergency medicine research. I'm also lucky enough to be involved in the Royal College of Emergency Medicine as their professor, which gives me the opportunity to work with great colleagues across the UK, to chair the grant committee and to have the privilege to read all about the upcoming research being planned across the country, and most importantly to grow academic emergency medicine and academic emergency medicine trainees who will be the ones to take our specialty forwards in future. A quick plug for the 2022 Royal College of Emergency Medicine undergraduate prizes, which have a deadline of 26th of February. They are open to medical students at a recognised teaching institution within the UK and are worth £500, membership of ARChem for a year, and a trip to the ARChem Scientific Conference in Belfast to present your work. So get entering. Here are my disclosures. The iPad, PatchED and Aspired studies which I mentioned are all non-commercial studies independently funded through research grants. So we're going to start first with syncope. Firstly, describing what it is, and then discussing why ED physicians sometimes struggle with managing it. I will talk about the current approach used, and then talk about some of the future focus using novel technology to make the diagnosis. To put syncope in context, it is responsible for around 400,000 of the almost 30 million presentations to UK EDs and just falls outside the top 10 commonest presentations in our emergency medicine department. Median length of stay is 1 day, about half of patients stay overnight, but the remainder stay for much longer. Half are admitted, with almost 3/4 being admitted directly to general and acute medicine. So what is syncope and why is it so difficult to manage? Well, as you can see, syncope is a transient loss of consciousness with complete recovery that is due to cerebral hypoperfusion. Unlike this poor television weather presenter, syncope is commonly unwitnessed. The patient has little recollection of events and therefore diagnosis can be difficult. So why else do we find these patients so difficult to assess and to manage? Well, firstly, there are some rare causes of syncope which most emergency physicians will be unlikely to see in their practicing lifetime. We sometimes have the opportunity to pick up and prevent the unfortunate events that these rare cases can lead to, such as this. Of course, the case of Fabrice Maramba, who had hypertrophic cardiomyopathy, the commonest cause of congenital cardiac disease. This ECG shows the classic hypertrophic cardiomyopathy pattern with voltage criteria for left ventricular hypertrophy and deep, narrow Q waves in the lateral leads, 1 AVL and V5 to V6. Another cause we need to look out for as emergency physicians is long QT syndrome. One famous case is of Olympic swimmer Dana Vollmer, who won a gold medal at the London Olympic Games in 2012. At the age of 15, Dana was diagnosed with long QT syndrome after experiencing a dizzy spell while training. Another topical, well-publicised serious cause of syncope. This one, the former England cricketer James Taylor, who was diagnosed with arrhythmogenic right ventricular cardiomyopathy after an episode of VT. His ECG shows T-wave inversion in V1 to 3, which is found in about 85% of patients, and the more specific finding of an epsilon wave, which is seen in about 30% of patients. The final ECG we cannot miss as emergency physicians is Brugada's. Here is the ECG showing the characteristic downsloping ST depression in V1 and V2, and the T-wave inversion. Treatment definitively is an implantable cardiodefibrillator, an undiagnosed Brugada syndrome has been estimated to have a mortality of about 10%. Another reason we find managing syncope difficult is that patients are well by the time they get to the emergency department. Their symptoms are settled, they have no signs, and sometimes their ECG is normal. Commonly their ECG is normal. Some patients with poor cerebral circulation may have slight confusion after a syncope event. However, most patients are back to normal, irrespective of the underlying cause, which makes it hard to pick up what caused the episode in the first place. So I advocate a three-part approach which I find helpful in the emergency department. Firstly, we need to ask, is this actually syncope? Secondly, we need to ask, is there an obvious underlying diagnosis? And thirdly, is the patient at risk of a cardiac cause of their syncope? So firstly, is it syncope? Syncope falls under the umbrella term transient loss of consciousness, which encompasses syncope and seizure. Syncope is transient loss of consciousness due to cerebral hypoperfusion. There are several other potential causes of the episode, and as you can see here, it is important to work out exactly which of them we are dealing with so we can go down the right diagnostic pathway. Secondly, we need to ask if there's an obvious diagnosis. For example, we need to ensure there is an underlying diagnosis of subarachnoid hemorrhage, aortic dissection, ruptured aortic aneurysm, or ectopic pregnancy. And obviously, if we diagnose them, we then go down the management pathway for that individual condition. Finally, having established the patient has syncope and established there's no underlying diagnosis, we need to ask, are they at high risk of a cardiac cause? ED management and disposition depends on risk stratifying the patient to either being at risk of a cardiac cause, for example arrhythmia or structural cardiac causes, or more likely having a lower risk reflex or orthostatic cause for the event. How are we going to do this? Well, my top 5 important aspects for an ED syncope assessment are number 1, history, number 2, history, number 3, history, number 4, ECG, and number 5, lying standing blood pressures. Just in case I didn't emphasize the importance of history, this is a case report of a 25-year-old male who had a transient loss of consciousness during a tandem skydive in New Zealand. On the face of it, pretty concerning. Any takers for which category of syncope this might fall in? So yes, this is a classic history for venous pooling and reduced return. Luckily, it was tandem and not solo, so I lived to tell the tale. Here is me 15 minutes later with much less grey hair, neurologically intact, although some maybe disagree, and a very impressive Trousseau sign. This demonstrates the importance of a clear history which gives us a diagnosis here. I'm not suggesting for 1 minute it should be mandatory to experience the condition you're having an academic interest in, or to feature in a case report on it. Syncope during exercise is important and a serious symptom, and again, history is key. A girl collapsing whilst running for the ball playing hockey is a slam dunk for cardiac syncope. A girl who felt unwell at half time, went to sit down, felt lightheaded, nauseated, and then collapsed, has not had cardiac syncope. Here, history is king again. We must always ask about family history, and this can be difficult. It's difficult to ask whether a patient has had a near relative who died young of an unexplained cause when we're trying to reassure them, or hopefully trying to put their mind at rest that what they presented with isn't serious. The first documented case of long QT syndrome was described in 1856 when a deaf girl died after her teacher yelled at her. Soon after being notified, the girl's parents reported that her older brother, also deaf, had previously died after a terrible fright. Sometimes this is the only sign that there may be a congenital underlying cardiac cause. The length of the pre-warning is also key. In reflex and vagal syncope, it is typically longer than with cardiac syncope, for which there is often no warning at all. A reminder that in your examination, always listen for the murmur of aortic stenosis. Always do lying, standing blood pressures and do them yourself. Get the patient up, do a blood pressure at 1 minute and 3 minutes, and note what symptoms the patient's getting. If you ask a nurse to do it or somebody else, you do not understand exactly how the patient was during their standing episode, and also it gives you a much better idea to both work out how symptomatic they were and also the opportunity to ask a little bit more about the history of the event. Always do a 12-lead ECG. Finally, blood tests and x-rays are rarely useful in the diagnosis and management of syncope. There have been a number of attempts to try to risk stratify patients using clinical decision rules to aid emergency physicians decide who to admit to hospital and who can be safely discharged from the emergency department. Unfortunately, many are not validated or not sufficiently accurate for clinical use. None have been widely adopted, none outperform emergency physicians, and most lead to increased admissions. So after risk stratifying, we must decide if the patient has any high-risk features requiring admission to hospital or assessment in a specialist clinic, or whether the patient has only low-risk features and can probably be discharged from the ED. And currently we use the ESC syncope guidelines, which were published in 2018 and feature a low-high risk categorization guideline, along with a guideline about how to manage the patients depending on what risk factors they have, which is shown here. However, if the patient is high risk and we're worried about arrhythmia, then in the ED, we want to be doing something better than trying to identifying potential high-risk patients, and we need to try and diagnose these high-risk cardiac causes, both structural and arrhythmic. So what's been holding us back? Well, unfortunately, up to now the technology hasn't really developed much further than when Norman Holter started working on ambulatory ECG monitoring in the late 1940s. You can see from this photo that it was not that portable, and a key component of his original first Holter monitor was a Second World War radio pack. However, the technology in current use is not much better, with the Holter monitor that was developed during the 50s and released in the early 60s commonly only able to record for 24 hours and is definitely not compatible with daily life, showering, running, etc. At last, the tech has caught up though, and there are now some ambulatory ECG monitors on the market that continuously record a single lead ECG for up to 14 days. And they can also be worn while showering and living our usual lives, so much more acceptable to patients. Our patched ED study took 86 patients with unexplained syncope from the ED and fitted them in the ED with an ambulatory patch ECG recorder. We compared this group to a standard care group, which was a historical cohort of 603 patients with unexplained syncope who also had no obvious diagnosis in the ED. Of these 86, we had 76 patches returned, having been worn by the patient for 14 days. 56 of these patches recorded a diagnostic finding, that is, an ECG recorded during the patient having symptoms, and they could record this in a diary or by pressing a button on the monitor. 34 of these 56 showed normal sinus rhythm or ectopic beats during the symptoms, meaning the patient could be discharged with a non-cardiac syncope diagnosis. But 9 patients recorded a serious arrhythmia during the symptoms, which was 10.5% of our population. This compared to only 2% who recorded symptoms in the first 90 days of our standard care group. This study demonstrates that patients whose syncope is unexplained in the ED do have a burden of disease that is frequent enough and serious enough to warrant further investigation. These significant arrhythmias occurred right up to 14 days, as you can see here from this graph, supporting a 2-week outpatient monitoring strategy. They were not all recorded in the first 24 hours, so bringing patients into hospital for monitoring overnight or putting on a 24-hour Holter monitor is not going to pick up most of these cases. This is Rob. one of our patients in the study who presented to the ED with syncope without prodrome and had significant trauma, spilling a cup of tea over himself while he had his loss of consciousness. His ambulatory ECG showed a 26-second pause. In view of the severity and regularity of his symptoms, Rob had 2 further episodes, all with associated trauma subsequent to his index presentation. A pacemaker was implanted, which halted the episodes. So following on from this, we now have a grant from the British Heart Foundation to fund a UK randomised controlled trial looking at 14-day monitoring started from the ED versus standard care monitoring in over 2,000 patients who will present acutely with unexplained syncope to EDs and acute medicine units across the country. Hopefully when I stand up before you in 5 years' time, this care will be offered to all unexplained ED syncope patients immediately following their attendance, and we will have moved from a risk stratification approach to an early diagnostic approach using novel ambulatory technology. Moving on from syncope, I'd now like to talk about palpitations. Again, this is another common ED problem. Most patients' palpitations are resolved by the time they come to the ED. And because palpitations alone don't lead to loss of consciousness, they are associated with less serious cardiac rhythms such as atrial fibrillation, atrial flutter, and SVT, supraventricular tachycardia. In the ED, we discharge patients home, telling them to return if they become symptomatic. And GPs and outpatient departments again persist in using Norman Holter's 24-hour monitors, which rarely capture a palpitation during the monitoring period. If the symptoms have settled, record a normal ECG. It's a very unsatisfying problem to try and deal with in the ED, as the patients have no evidence that they have had any episode, and we cannot use aspects of the presentation to be able to differentiate between a atrial fibrillation or sinus supraventricular tachycardia versus ectopic beats or sinus tachycardia, which are obviously benign. So the new kid on the block here is an event recorder called the AliveCore. Because the patient is conscious when they get symptoms, they can use this technology that can be carried around with them in their pocket or handbag and taken out to record an ECG when they get symptoms. When they do, the patient places 2 fingers from each hand onto the electrodes in the vicinity of their phone and records an ECG. This is then saved onto their phone. They can take it to their GP or to their clinic appointment, and they can get an instant diagnosis. So we designed the IPED study, which randomised 243 patients who presented with palpitations or pre-syncope, that is near collapse but not loss of consciousness, that remained undiagnosed after being seen in the ED, with no diagnostic ECG recorded. And we performed this in 10 UK emergency departments. Patients were randomised either to using the AliveCore device for 90 days or standard care, which in most hospitals is the Holter monitor. We randomised 126 patients to the intervention, that is the AliveCore device, and 117 to the control arm. Most patients presented with palpitations, and the majority of our study cohort were female. So what were the results? Well, our primary outcome was symptomatic rhythm at 90 days. And we found that in the intervention group, 69 patients, that's 56%, recorded a symptomatic rhythm, whereas in the control group, only 10% recorded a symptomatic rhythm. That is, an ECG recorded whilst they were having symptoms, which therefore diagnosed the patient. So what symptomatic rhythms did we record? Well, almost 85% of patients had sinus rhythm, sinus tachycardia, or ectopic beats. And this is fairly standard in palpitations research. About 85% of patients across most studies show benign rhythms such as this. Now this is very important because we can reassure the patient that their palpitations aren't due to a cardiac arrhythmia, and they can be reassured and coached how to be less concerned about them and for them to be less symptomatic when they have these events. However, we found about 9% patients had atrial fibrillation or atrial flutter, about 4% had SVT, and there were some other rhythms that were recorded as well that required treatment. Our secondary outcome looked at the time to detecting the symptomatic rhythm, and in the intervention group we did this in a median of 9.5 days. However, it took almost 43 days for a symptomatic rhythm to be detected in the control group. As you can see, this was significant. We also looked at how many patients recorded a symptomatic cardiac arrhythmia. So this is the atrial fibrillations, atrial flutters, SVTs. We found 11 patients in the intervention group versus only 1 patient in our control group at 90 days had a symptomatic cardiac arrhythmia. And as we randomized patients, we know there are 10 patients in the control group who have a cardiac arrhythmia which has not yet been detected. We also found that with economic analysis that using the intervention was cost effective. We looked at patient satisfaction as well, and overwhelmingly the patients were satisfied with using the device and found it easy to use. So on the back of this, we set up a smartphone palpitation service in our hospital which could be accessed from the ED and the acute medicine unit. And if patients presented with palpitations, their ECG was normal and we had no evidence of the underlying rhythm on ECG during their presentation, they had a suitable watch or smartphone, then we could bring the patient back to the next day ambulatory care clinic where they were fitted with a device. The idea here was to pick up cardiac causes of palpitations. In the iPED study, we found that 93% of the participants of the study who recorded a symptomatic rhythm did so during the first 28 days. So therefore, we decided that when we set up the clinic, rather than giving the patient the device away for 3 months, 90 days, that we would give them away for a month, as there was a really good chance, 9 in 10 chance of us picking up the symptomatic rhythm during that month. And that meant that we could get through more patients and have better use of the devices. So we established the clinic on the 22nd of July 2019. And it was based in the ambulatory care part of our hospital. We had patients being referred from the emergency department and the acute medicine unit. And as I said, the patients were reviewed at 4 weeks rather than the 90 days in the iPED study. If they did come back at 4 weeks and they had no records and no diagnosis, we could send them away with the device for another 4 or 8 weeks, or even longer, until we managed to capture a symptomatic rhythm, i.e. one recorded during episodes. And we looked at our first year of practice. So during this time, 290 patients were referred to the clinic. We saw 282 in the clinic, and we fitted 237 with the device. Of those 237 patients, we detected a cardiac diagnosis in 17 of these, so just over 7%. Again, similar to the iPED study. We found 10 episodes of atrial fibrillation, 5 of SVT, 1 episode of atrial flutter, and 1 episode of atrial tachycardia. And as you can see, the majority again were non-cardiac diagnoses, such as sinus rhythm, multiple ectopic beats, and sinus tachycardia. After our initial audit, we were actually audited after 3 months as well. We made some changes and improvements to the clinic. Things such as getting the patient to download the cardio app before they came back to clinic to save time, and also because our hospital Wi-Fi is not brilliant. We changed the referral guideline slightly in our emergency department and our acute medicine unit to make sure we're trying to focus on patients where there was a high suspicion of a cardiac dysrhythmia, as opposed to patients who most likely had benign causes. And this was mainly patients who had multiple episodes, multiple daily episodes, where there was a much better chance of just capturing an ECG in the ED, for example, or just popping them on a monitor for an hour, or where clearly there was an anxiety or non-cardiac rhythm being the most likely cause. Because we didn't want to overwhelm the clinic with those type of patients, we were very keen to try and pick up cardiac causes as well. We better logged devices so that we could have a better turnover of them and know how many devices we had and who had them at any times. And we made sure that we changed the batteries every 12 months routinely. So again, good logging of the device, which is really important. So it's very doable. The clinic's still running extremely well and was in fact just awarded the Arrhythmia Alliance Expert Prize for Expert Practice in 2021. So where next? Last month, NICE deemed the AliveCore device suitable for the detection of AF and also cost effective for the detection of AF in patients with palpitations. So this will now start to become standard care across England and Wales, which is covered by NICE. And it's not the only way to record an ECG using a LivResCon device. Most of you will be aware of the Apple smartwatch, whose version 4 and above can record an ECG. And there's no reason why a device such as this can't be used in patients with palpitations. Your wristwatch can now record you being in AF, lead you to getting treatment and prevent you having a stroke. What would have Norman Holter thought of this? Other devices being developed include YoHeart, which is the device you can see on the right here, which will enable equity of care in that this device does not require patients to have a smartphone, which is the current method for recording ECGs. You need to have a smartphone or a smartwatch or a smartphone for you to be able to download your AliveCore ECG2. So technology such as this will make care much more equitable to be accessed by all patients. So to wrap up and summarise, I presented today about two cardiovascular conditions that commonly present to the emergency department, syncope and palpitations, which I think it's fair to say many emergency physicians find difficult to manage because the diagnosis is not always obvious in the emergency department. Previously, we have tried to risk stratify patients using clinical decision rules and more recently the European Society of Cardiology guidelines, which does allow us to focus much better on which patients may have a high-risk cardiac cause and which patients may have low-risk causes. However, it doesn't really help us really pin down the underlying diagnosis. And I presented two strategies. One which is in a research setting at the moment, the syncope strategy with early 14-day continuous monitoring, and the palpitation strategy using an event recorder over a period of time to try and pick up the underlying rhythm and record an ECG while events are actually happening, whilst the cardiac event's actually happening. And these two strategies focus on early diagnostic testing from the ED using novel ambulatory monitoring technology and digital biomarkers. These, I think, are where we're going in the future with these two conditions, and also for potentially many other conditions that we see in emergency medicine and across medicine in general, where ambulatory monitoring technology and digital biomarkers will start to play a much more important part of our practice. I think it's hugely important that we share good practice in these areas and that we widely adopt this good practice for the benefit of our patients. Thank you again for the invitation to speak to you today, and I hope you all enjoy the rest of your conference. Thank you.